Good afternoon, everyone, and I'd like to invite you to this session on cataract surgery in troubled cornea, which is going to be a case-based discussion with surgical video. We have a very short introductory presentation by my co-moderator, Dr. Shreya Thate.
So very good afternoon, everyone. I welcome you all on this AIOC 2023 Kochi in this turquoise hall to attend this very interesting instruction course on cataract surgery in troubled cornea, and this will be a case-based video discussion in surgical videos. So in this we come across many times these type of corneal pathologies when we are doing the cataract surgeries, and we have dilemma how to proceed in this, and many times we have this pre-existing OSD. So this is moving. So many times we have pre-existing OSD and there is issue in preoperative evaluation. And in post-operative period also there is exacerbation of this dry eye, and how to overcome these problems. Dr. Charuta Puranik is going to talk about the cataract surgery in dry eye. Another thing, we come across the corneal scars along with the cataract, where there is problem of impending visualization, there is difficult in biometry, intraoperative difficulties. So this is going to cover by me, managing cataract with the corneal scars. Many times we see that less number of functioning endothelial cells in case of Fuchs, which we may not diagnose while doing the cataract surgery if we don't do the specular, and we need certain modification of surgical steps and how to achieve the successful outcome. This is going to talk about all these things, cataract surgery in Fuchs endothelial dystrophy by Dr. Sushmita Shah. We may come across many times that post keratoplasty there is cataract formation is there, and here we need attention to stability and optimization of the corneal graft. We need to have good IOL selection and preservation of the graft. So Dr. Pratik Gujar is going to talk about post keratoplasty challenge in cataract surgery. LASIK is nowadays another very big challenge, and this is a unique challenge where the high expectations of excellent visual outcomes to the patient, because they are spectacle independent, and there is always difficulty in calculation of the intraocular lens power predictions and all. So Dr. Hijab Mehta is going to talk about achieving accuracy of biometry in post refractive surgery cataract. Though RK we don't see many cases now, but when we see, there is always difficulty in achieving the target refraction. There is decreased corneal integrity, and there is unexpected corneal astigmatism. So how to deal these problems in a case of cataract? Dr. Ritesh is going to talk about difficulty faced in post RK eyes. Then we may come across many ectatic corneas where there is problem of keratometric measurements. Axial length is another problem, and there are several approaches are there which can minimize the refractive surprises in such ectatic corneas. And Dr. Kavita Rao is going to talk about cataract surgery in corneal ectasia and overcoming the problem. Last but not the least, we do see many cases of pterygium in our routine practice where we are dealing with the cataract, and we know that it can induce the astigmatism, and there is always dilemma whether to go for the simultaneous approach or sequential approach. So Dr. Meena Lakshmipati is going to talk about the cataract surgery in pterygium, how to approach. So this is the course outline. I hand over mic to Sushmita to go ahead with the session.
Thank you, madam, for a great introduction. So with that, I invite Dr. Charuta Puranik for the first presentation, which is going to be cataract surgery in dry eye disease.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Sushmita and Dr. Thate for inviting me for this session. My topic for the day is cataract surgery in dry eye disease, and I've tried to include a couple of interesting cases also which we had to manage. One of the interesting cases is a case of Stevens-Johnson syndrome with a corneal scarring, and the patient had recurrent perforations. And the other video based is the one of severe dry eye disease in primary Sjogren's. एक minute. Yes. Thank you.
Should we take the next talk until you organize this, or if there's a problem?
अगला वाला चलेगा क्या? अगला
I
वाला
think
चलेगा?
I think yeah. So Charuta's presentation, we'll just upload it. So I request Dr. Shreya Thate to present her talk, Managing Cataract in Corneal Scars.
So good afternoon again. I'm going to talk about managing cataract with corneal scars. So we do come across these type of corneal scars with the cataract, and how to deal is a big problem because there is impending visualization, there is problem of biometry, intraoperative difficulties, and there are many options available, like you can go for the cataract surgery alone or simultaneous keratoplasty and cataract surgery, or you can go for the cataract surgery after keratoplasty. And these options are available on various factors like location and density of the opacity, whether the patient is status of the patient, monocular or binocular status, then surgeon expertise, availability of the donor cornea, and patient expectation. All these factors depends how to choose the option. When opacity is peripheral or paracentral and one half of the cornea is clear, that time we can go for the cataract surgery alone, which gives faster visual rehabilitation, but there is always difficulty in the surgery. When we go for the simultaneous keratoplasty and cataract surgery, there is shorter visual rehabilitation period, but there is greater risk of the complication and risk for the graft failure. If we go for the cataract surgery after keratoplasty, there is achievement of the refractive accuracy, but always risk of endothelial loss and graft rejection. When we do the cataract surgery alone, certain modifications are required. We will just talk about one by one. Site of incision should be one which provides the maximum clear working field. Means if the opacity is in the inferior part, you can make the incision at the 12 o'clock position so that you get a clear area. You should use the maximum, you should take the maximum use of OVDs, as they not only provide the lubrication when they are placed over the corneal surface, but they also increases the magnification and they provides better visualization, and you can use repeatedly several times during the surgery. Illumination is the another factor which can give you good visualization. You can change the position of the patient's eyeball to get a good illumination. You can change the position of the microscopic intensity of the light, or you can use the retroillumination or the by fiber optic light, as you are seeing here. You can see the clearly, and then you can go for the further steps by using this fiber optic light, or transconjunctival chandelier illumination can be used. Pupillary expanders are required in such cases because often there is atonic iris is there, there is pre-existing posterior synechias, poorly dilated pupil is there. So pupillary expanders, they not only expand the working area, but they can expand the pupil beyond the corneal opacity, so that the visibility is increased, and enhanced visibility provides good surgical steps with less complications. Capsular rhexis is another important step. So after staining, you should start the capsular rhexis in the visible area where you can see the clearly see the lens and capsule. Start with the whatever way you want to start. Use viscoelastics as and when required. This was case of hypermature cataract, so the liquid fluid was coming out, so drain out the fluid so that you can keep on identifying the capsular edge. Underneath the corneal opacity, you can use the forceps, hold the edge of the capsule, and then in a single motion in the centripetal direction you can complete the rhexis. But if you leave the edge, again use the viscoelastics, and then you can rehold the rhexis. Nucleus emulsification is also not so easy. Always be in the clear area where you can see the nucleus, whether it is hard cataract or any type of nucleus grading. You can do it clearly if you are there in the clear area of the opacity. So in case of hard cataract, you can go for the eccentric crater and chopping. And if there is, as soon as you start eating up the nucleus fragments, the clarity increases and rest of the things can be easier. Intraocular lens implantation, in case of paracentral opacity, you can put the large size of lens so that it can cover the larger area. Simultaneous keratoplasty and cataract surgery, you require little expertise, and when there is full thickness corneal opacity and central corneal opacity, donor button is available, you can go for it. I always do the UBM before going for the penetrating keratoplasty in such cases, because then only I can predict that whether there is cataract is dense or not, whether status of the whether it is aphakic or not. So in the lower one, I could already knew that this is aphakic patient, so I make for the scleral fixated, I was prepared for the scleral fixated IOLs. So after removing that cortical matter and doing the anterior vitrectomy, I just this inserted 3-piece lens for the scleral fixated, and one haptic is out now, and then the another haptic was taken out and fixed in the groove. But it is not very easy while doing the open sky keratoplasty, while penetrating keratoplasty, as the globe is very, very soft, so it is little difficult to handle it. And in another case video, you can see the open sky rhexis was done, and then the lens was removed, and then PCIOL was inserted. Well, so this way you can manage whether you want to go for the cataract surgery alone or simultaneous keratoplasty. Cataract surgery after keratoplasty, Dr. Pratik Gujar is going to cover, so I'm not going to talk about this. So this is the way you can manage by certain modification for the better visualization. You can go for the cataract surgery in the corneal scars. Thank you.
Thank you, madam. So we'll take questions little later in the end. So I request Charuta to please present her talk.
Good evening, everyone. So I'll jump straight to my talk. And so the challenges typically, even when there is a dry eye disease, is not just limited to the choice of IOL or the type of cataract surgery, but also begin right before, that is the inaccurate biometry, deficient media clarity because of the scarring and variable thinning. And also there is a worry about exacerbation of underlying immunoetiology, especially in cases like Stevens-Johnson's or OCP. Now, the series of inflammatory events which are initiated by the surgical trauma of cataract surgery may also lead to corneal melts and perforation. Now, pre-operative, the nuances include in the in the lids we can see meibomian gland dysfunction, which possibly could lead to secondary infection post surgery because we are going to be giving steroids. Malposition of the lids may be pre-existing, which may lead to an epithelial defect, again interfering with our use of steroids. Pre-existent trichiasis, entropy and ectropion may also lead to secondary infections, as well as presence of lid margin keratinization. Now, presence of aqueous tear deficiency, the tear film may be inadequate, and this may lead to a presence of punctate epithelial erosions or a non-healing epithelial defect, and it may predispose to secondary infections. Fornical shortening, as seen in SJS or OCP, we may need to rule out the underlying immune etiology and address the fornical shortening only if it is going to interfere with cataract surgery. In other situations where the fornical shortening or presence of symblepharon will be addressed before cataract surgery is if we are planning that the patient is having a scar and we would want to use a scleral contact lens post-operatively for addressing the same. So this is a case of severe dry eye disease with peripheral. There is some scarring, and there is a central very faint nebular macular grade haze. As we see over the course of the cataract surgery, sometimes these scars tend to become larger and more opaque, making the surgery, which seemed very straightforward or only slightly challenging, to become more and more challenging. So this case we have planned for a small incision cataract surgery because the density of the cataract was very high, and also because the scar is central, and also there is some presence of peripheral scarring. During the preparation, topical paracaine was also instilled inadvertently, although I prefer in all these cases to operate only under peribulbar block. Therefore, while inserting the speculum, the epithelium had become loose and had to be removed. However, it must be noted that we must preserve the epithelium as much as possible in these cases. I'm using the red glow over here because the pupil is slightly larger than the central scar in order to make the rhexis. And as Dr. Tate has very beautifully elaborated on how to make the rhexis in the presence of such a scar, I'll skip this area. However, it's important to note that we need not stick to or make it an ego issue to make a rhexis. You can always convert to a can opener technique, especially when you have already planned for a 3-piece lens. It is preferable to make the entry and plan your tunnel in a non-scarred area and an area which is not thin. In the for cortical aspiration also, it is better to use chandelier type of illumination in order to make it easier. As we can see, the cases become slightly more hazy, and the presence of an external illumination source is making it much easier, although not faster, to remove the cortical matter. 3-piece lens is then placed it is aimed to be placed either in the bag or in the sulcus, especially because we know that there may be tags. If the cortical matter edges are still visible, then we can go ahead and repeat the chandelier illumination and repeat the cortical aspiration even after placing the lens. It is important in irregular or scarred corneas, and especially in dry eye disease where we have planned an SICS. Even if your tunnel is well sealed, it is better to put a suture. So these are some of the points which I mentioned. Prophylactic topical antibiotics are also preferred because we must remember that in dry eye disease, the surface commensals are already altered, and therefore we need to use topical. It's preferable to use topical antibiotics. Local anesthesia or general anesthesia, if required, may be preferred, and as compared to a topical one. It is important to inform the staff not to excessively irrigate or use excessive light because these patients are already photophobic. Prefer clear corneal if phacoemulsification if it is possible, or if required, as seen, can perform SICS or ECC. Choice of incision should depend on the location of the scar, if at all, and coat the cornea with viscoelastic if required. These points we have already discussed. Also, what we didn't see in the video was preference of optical iridectomy if it indicated, if we feel that the visual acuity, dilated visual acuity preoperatively was better. Reduce the use of NSAIDs postoperatively. Now, specific points about aqueous deficiency. Investigate for the cause of aqueous deficiency before the surgery. If you are suspecting Sjogren's, it's better to refer to a rheumatologist before taking up even elective cataract surgery, because if the condition is in remission or is having low disease activity, then the question doesn't arise. But however, if it is not and it is very active, then immunomodulator or DMARDs may be stepped up as required. An emergency cataract surgery may warrant preoperative steroids. Treatment with topical autologous serum is also preferred. In SJS, typically punctal occlusion makes a lot of difference. The other parts such as lid margin keratinization can be corrected surgically, either with lenses, pros lenses, or with mucous membrane grafting, and fornical shortening, as mentioned before, can be managed. This is another challenging case wherein there was a total cataract and the patient was having repeated perforations in a case of SJS. You can see the lid margin keratinization over here, and which is recurring, and there is a presence of a mucous membrane graft which had been done prior. This patient continued to perforate until we removed the cataract with the help of phacoaspiration, and then repeated the multi-layered amniotic membrane grafting. Post this, she improved tremendously, and the perforation did not recur. Now, post-operatively, what are the challenges? Despite adequate condition of control of the systemic condition, also there can be worsening of the dry eye symptoms themselves. Therefore, we need to remember to include in our regimen of post-operative cataract surgeries more frequent lubricants. Corneal defects, melts or infections may still occur, and therefore a more frequent follow-up is preferred. PTK or PTK alone or with PRK can be performed in very, very select cases, very, very rarely, to correct the minimal residual refractive error. And very cautious use of RGP or contact lenses also can be done in cases of emetropia, where the patient is very compliant. Scleral contact lenses can be preferred, especially in post-cataract surgeries patients with Stevens-Johnson syndrome, to improve both the comfort and also the visual acuity for dry eyes and for the management of the corneal scars. Thank you very much.
Very nicely presented. Many questions which has arisen all are covered in this talk. And next, I call Sushmita to talk about the cataract surgery in Fuchs endothelial dystrophy. Meanwhile, she's preparing, the slides are prepared. Can I ask one question to Charuta? Before surgery, do you prefer to do give some treatment before doing cataract in this dry eye patient when you decide to go for the surgery in this dry eye?
If you ask for one single factor, then I look
No,
at the erosions.
no, all other
In
factors.
general,
And
so
in
we
general.
continue the lubricants as usual. I prefer to wait for all the PEs to resolve as much as possible, and also if there is filamentous keratopathy, for the filaments to be absent. So that I know is the both conjunctival and corneal erosions should be staining negative.
Thank you.
Yeah, good afternoon, everyone, and I thank AIOS Shriya ma'am for this opportunity. And continuing with cataract surgery in troubled cornea, I would like to discuss about cataract surgery in Fuchs endothelial dystrophy. So I'll start with a case of a 52-year-old female who presented to us with decreased vision in both eyes since 6 months, and had worse vision in the right eye, which was 618 N8 with correction, and 612 N8 in the left eye. And there was diffuse guttae in both eyes, right more than left, and nucleosclerosis of grade 3 in the right eye and a grade 2 in the left eye. So the diagnosis was of Fuchs endothelial corneal dystrophy and cataract. So now the big question that one faces is whether to do a cataract surgery alone or to do a combined cataract surgery with a endothelial keratoplasty. So starting with Fuchs as described by Krashmer, has been graded from grade 0, which is no disease, to grade 5 to grade 6. The grade 1 is early disease, where you can just see about 0 to 12 central guttae, and grade 2 is more than 12, and of course non-confluent guttae. But it is usually the grade 5 which has more than 5 millimeter of central confluent guttae, or grade 6, which is a which is grade 5 with additional epithelial prostromal edema, which are the ones which need major corneal interventions. Now, the other important, apart from a clinical examination, important preoperative diagnostics include specular microscopy, which provides data on the endothelial cell count and morphology. Usually less than 1,000 cells may lead to corneal decompensation, and that needs to be explained to the patient. However, the problem with specular microscopy is that in advanced cases, he may not be able to even obtain any data. Under such circumstances, confocal microscopy can be used, and it gives endothelial cell count as morphology, as well as it can document guttae, and is useful even in advanced cases, but it is an expensive tool and it is not very easily available. The other important preoperative consideration is pachymetry, or the central corneal thickness. One could use a Scheimpflug topographer or a ultrasonic device. Even the specular microscope gives the central corneal thickness. Now, the central corneal thickness increases due to endothelial dysfunction, and in typically what Fuchs dystrophy, the increased central corneal thickness is noted centrally, as compared to other endothelial pathologies in which that endothelial dysfunction could be diffuse or it could be localized anywhere. Now, coming to these recent papers from the Mayo Clinic, which have tried to grade Fuchs dystrophy based on the Scheimpflug topography. They used a pentacam. So they've described 3 distinct features to grade the Fuchs dystrophy. The first is the displacement of the thinnest point of the cornea, loss of the parallel and circular oval isopax, and third is the focal area of posterior surface depression. That is, the posterior surface bends towards the anterior capsule, that is inwards. So these are the 3 characteristics which they have noted on the pentacam, and based on this is the grading that they have described from down up, which is the no Fuchs dystrophy, where you don't see guttae and it's a normal cornea. Then you could have Fuchs endothelial dystrophy but no edema, where clinically you will see guttae, but on the Scheimpflug topography you may not see any of the features which were described, which I just described. The third category is the Fuchs dystrophy with subclinical edema, where you will get guttae, which are typically confluent, but any without clinically definite edema. And here, any of 2 of the features of pentacam, the Scheimpflug topography, could be present. And the fourth category is the Fuchs endothelial corneal dystrophy with clinically definite edema, where not only guttae are present, there is visible corneal edema, and the tomographic features, all 3 are usually present. So these are the more severe cases, but they have classified it, but they have not provided any guidelines as to which treatment modality one should go for, whether to go in which situation, whether to go for a cataract alone or a combined procedure. So now coming back to our patient here, what we noted a displacement of the thinnest point of the cornea, and also the loss of parallel or circular oval isopax. So, and here maybe when you see the slit lamp, just the center, we could see a mild thickening of the central cornea. So there was possibly some amount of subclinical edema there. The specular microscopy, we didn't get any counts, though we could see some images, but not much of count. The pachymetry was 525, and also here you can see that it is around 557. So how does one approach such a case? So this is another paper by Moshirfa et al. Published last year, which talks about how to choose between simultaneous versus sequential surgery. So it essentially based on the central corneal thickness. If it is less than if it is more than 640 microns, then you do the specular microscopy, and based on the specular microscopic findings, if its counts are less, then definitely you need to do a combined. If it is not, if it is reasonable, then you could still explain the prognosis to the patient. The other thing is, if the central corneal thickness is less than say 640 microns, and if you do the endothelial cell density which is less than 500, then you definitely need to do a combined procedure. procedure. If it is less than 1000, you could choose preferably even cataract, or if you want, you can even do a combined procedure. But if you're doing a cataract, you need to explain the possibility of combined procedure in the future. And if the endothelial cell density is more than 1000, then you can safely go ahead and do a cataract surgery alone. So we chose to do a combined procedure for this lady. So that's the clinical photograph which I had shown earlier. So as you can see, the black dots in the center, these are very suggestive of gute. You can see that nicely. Now I've caused a small descemet membrane at the detachment at the where I entered the AC. Not a good idea to continue there. So a good sense prevails, and I make another side port and avoid that area. Once the rhexis is done, we remove the enterocapsule hydrodissection. Now very critical is the soft shell technique, is to first use dispersive viscoelastic to coat the endothelium, followed by cohesive viscoelastic under the dispersive viscoelastic. And also important to use the BSS, which has the oxidized glutathione, which is endothelial protective. Now here, unfortunately, my trench is not very centered, so I get a divide which is not equal. It's kind of 2/3, 1/3, but still I continue with that. And important to remember to inject both viscoelastics repeatedly. We remove the small fragment first. Remember to keep the phaco tip as far away from the endothelium as possible. Divide the nucleus into smaller fragments, so that if you have bigger fragments, the chances of those hitting the endothelium is much more. As much as possible in the bag, phacoemulsification should be done. So these nucleus pieces chattering away, again, you should avoid them hitting the endothelium and try and keep their control, keep the movement minimums. Then repeated injection of viscoelastic. I cannot highlight this more. The soft shell technique, both cohesive and the dispersive viscoelastic. The routine epinucleus removal, and then the cortical wash. This is the dispersive. Coming to the intraocular lens, it has to be carefully implanted. Make sure it doesn't touch the endothelium anywhere, and we always try and put a hydrophobic acrylic IOL, because if you need a endothelial keratoplasty in the future, hydrophobic acrylic is the best material. Try and remove of all viscoelastic. There is this lady who improved to 6, 9, and 6. So just to summarize, careful clinical examination, and to look for the gute, specular microscopy, look for corneal edema. Progressive nature of Fuchs endothelial dystrophy needs to be explained if you're doing cataract surgery alone. Soft shell technique is most important. Sorry. And in the back, phacoemulsification, and should also keep the nuclear fragments away from the endothelium. Repeated injection of cohesive and dispersive viscoelastic, and also use sharp blades to avoid descemet membrane detachment. Thank you.
Thank you, Sushmita. It was A to Z of Fuchs dystrophy with cataract. Next, I call Dr. Pratik Gujar to talk about the post-keratoplasty challenge of cataract surgery. I just request to the speakers, just stick to the time.
Yeah, I would like to thank Dr. Shreya Thatte and Dr. Shah for this wonderful opportunity. This one only. So I shall be speaking on post-keratoplasty challenges in cataract surgery. So there are a lot of challenges in these case scenarios, because first of all, the counseling is quite different and takes a bit of time, because these patients might not have that good visual outcome as compared to routine cataract patients. So the chair time, preoperative chair time is more for these challenges. Other challenges which are involved are like IOL power calculation, controlling of the astigmatism, choice of the IOL, and during the surgery, endothelial protection. And the post-operative care is a little bit different from a routine cataract surgery. So to begin with, you have to start with the clinical examination of the graft, how it is, the clarity of the graft. A specular microscopy you need to do to see the endothelial cell status, and then you can manage the astigmatism, do a topography, and you can do a selective suture removal to stabilize your K values, regularize the cornea more, and once it is regularized, you have repeatable topography with you. Then you can go ahead with your IL power calculation and IL selection. Usually even for a regular corneal astigmatism, you can plan for a toric IOL. In post DMAC eyes, sometimes you might get away even with a multifocal IOL, but that is strictly limited to a DMAC, post DMAC eye. These patients might have surprises, so it's important for us to examine them just before the surgery, like this guy who was planned for cataract surgery, but when I saw him just before the surgery, I saw that the patient had edema of the graft and KPs and a reactivation of viral keratouveitis. So it's very important that to examine these patients preoperatively, just on the day of surgery also. So you might have few surprises in these patients. Intraoperatively, these patients, of course, the role of endothelial protection, as described by Dr. Sushmita Shah, the use of a double shell technique is very important in these patients to prevent the endothelium. And these patients also have some anterior chamber complexities. The cases are not usually straightforward, like this patient with complicated cataract and posterior synecdoche. These patients might have also peripheral anterior synecdoches also, and the IOP issues are always there. So you have to check on all these levels. Again, this patient, you can see a lot of peripheral synecdoche and a complicated cataract. So IOL expanders, as described by Dr. Share Tate previously, can be useful in these cases also. This is a small clip of phaco in a patient with post-therapeutic keratoplasty. Once you get to have a repeatable topography, you can just do your IL power calculation and start your surgery. I want to highlight that I have made a scleral corneal tunnel to be as far from the graft toes junction as possible, because if you are going clear corneal, just to be a little bit cautious that you not disturb the graft toes junction. In this patient also had peripheral anterior synecdoches, so you have to release them, and using soft shell technique, again you can complete the phacoemulsification in the most routine way. This is another case in which the patient had a penetrating keratoplasty done elsewhere. She was a 20-year-old female who had a penetrating keratoplasty for keratoconus, and she then presented to us with a clear graft but highly irregular astigmatism. So to correct it, we adopted an approach of resuturing combined with phacoemulsification. As you can see, the Myers are so distorted. The graft was clear, so we were like, we have to retain this graft. So we started with a scleral corneal tunnel incision, as I said before, and then the cataract surgery was done in protecting the endothelium, and then making a rhexis. As this was a 20-year-old female, the cataract was not very hard, so just by doing irrigation aspiration, we get away with this cataract. And once IOL implantation was done, we injected pilocarpine to bring down the pupil, and then air was injected, and then all the sutures which were present previously were removed, and the graft host junction was partially opened, and a resuturing was started in this patient. The IL power calculation, I forgot to mention that we used standard K for this patient for IL power calculation, and then resuturing was done, which was like combined suturing, in which first 8 interrupted sutures and then 16-bit continuous suture was done, so that a better intraoperative astigmatism correction can be done. So as you can see, the Myers become much better once we regularize the astigmatism, and this kid is under our follow for last 2 years, and the astigmatism, you can appreciate that the average K which is here is like 45.75, which is pretty much close to our standard K, and even after 2 years this kid is doing great. Post-operatively, yes, as I said before, these patients require a closer follow-up as compared to the routine cataract patients, and you might want to hike up the steroids, both topically and systemically, to maintain the graft functionality. Intraocular pressure issues are to be tackled even pre-operative period and post-operative period. Patients who had underwent keratoplasty for viral keratitis, you need to hike up antiviral. You have to give antiviral cover at least 7 days prior to the surgery, and you have to continue it for at least 3 months post surgery. Thank you for your patient listening.
Thank you, Pratik. Very elegant. So we'll take questions in the end. Next talk, I request Dr. Kavita Rao to present cataract surgery in corneal ectasia, overcoming the problem.
Thank you, Dr. Sushmita and the esteemed panel for having me here. I'm talking about optimizing cataract surgery in corneal ectasia. I think all of us who are dealing with cataract surgery with keratoconus are dealing with these three categories of patient where you're doing cataract surgery alone, or you're doing a combined surgery, or you've done keratoplasty at some point when the patient is younger and now you're planning the cataract surgery. So I'm just going to talk very briefly about the nuances in each of that. And when you're dealing with doing cataract surgery alone, so obviously it's going to be in a non-progressive ectasia. So when it's naturally non-progressive is when it's an older patient, probably in his 50s or 40s, where he's not progressing, or in the younger patient where you already like addressed his ectasia and you've made sure that you've treated the ectasia and the progression of it. Or if it's a happy contact lens user, where he's got advanced ectasia, but in the older patient, but he doesn't want to address the cornea in the sense, doesn't want a keratoplasty, he's a happy contact lens user and he's not willing, or logistically you don't want to do that. And if it's an advanced keratoconus, then you can still just go ahead with cataract surgery and rehabilitate him with the contact lens. Now toric IOL, it's a big bugbear whether we use, don't use. So obviously if the astigmatism is more regular, then you use that. How do you decide that? Look at the topography, look at the holiday AKI report. Even if you don't have any fancy equipment, you just look at your basic topography. That itself will give you an idea. If the most of the cone is in the central area, if it's a central cone, then you can go ahead with using a toric IOL. But if it's an absolutely decentered cone, then those are the cases where you're not going to get good results with the toric IOL. Then the EKR report, if the reading is like this, I think that's fairly acceptable rather than something like this. Now, when you do it after 6 months minimum, you need to wait. After cross-linking, you can see most of the time that stabilizes, though of course at 11 months, it's obviously ideal. This is a 16-year-old girl with chronic allergic conjunctivitis, with progressive K-conus, with a posterior subcapsular cataract. So we had to address all of that, treat her allergy, then treat the cross-linking. Both the eyes cross-linking was done, and 6 months after that, we planned the toric IOL. Now, these are different cases where I've used toric IOL. You can go ahead with using, image-guided system or manual marking, whatever you may have. So that I've marked it directly with a pen there. But you know what? Nowadays, what I do is I use a Sinsky hook and I use that for marking because it's a much more fine and marking. Here on the left-hand side, you can see at the end of surgery, sometimes I feel, especially in patients with a deeper AC, if you're very forceful during the hydration, you can see that IOL has just rotated. So be a little mindful of that in the toric IOL. Make sure you're being careful about that. And in very high myopes along with ectasia, you should go ahead and probably put in a CTR is what the understanding is. If you're doing a keratoplasty first, then all sutures have to be out when you're planning a cataract surgery, and 3 months after suture removal. So that way we're looking at about a year to year and a half in after keratoplasty, never before that. Toric IOL is definitely useful. PTKs can be done. This was a case where I planned to do a toric IOL because it was though a very high astigmatism patient was it was irregular. Make sure you're protecting the endothelium. That would be the only mantra I would say. And also protecting the epithelium, because in these cases, as we know that sometimes, epithelial defects, if you land up with that, they're also a little bit more difficult to heal versus say a normal cornea. So in these cases, use a soft shell technique, use trypan blue if you feel like the this cataract is dense. Here, as you can see, protecting the epithelium and the endothelium with a lot of viscoelastic. and then you can go ahead with placing your toric IOL and get a great result. Now this is how it looks when you're doing suture removal. You're not removing all sutures and you keep calling the patient back. Eventually patient does the well and gets 6/6 best corrected or unaided vision. Now this is a patient where actually if you see it's a graft and he had almost like a hydrops in his graft and edema, operated at Moorfields for this graft, and other eye also he has advanced keratoconus and not getting the keratoconus readings. So even though ideally this was an ideal candidate for say a triple surgery, I still decided to not, because I wasn't getting any kind of keratometry readings. So I did a phase surgery, like sequential surgery, did all the did a graft, got all sutures out, and then planned a toric IOL. And this is a I think 6/9 unaided patient. He's doing really well. Again, if you're doing DALC also after surgery, then get all the sutures out, and then eventually at the end of it is when you're going to plan surgery once all the sutures out. And DALC probably I think 6 months after that is good enough. You can get all the sutures out and then plan your cataract surgery. If you're combining, obviously if it's very advanced ectasia, patient cannot have two procedures, then you do that. Ideally pick PK with DALC because rather than DALC, because when DALC is a high chances of perforation, you can go up till the anterior stroma and still complete your DALC. Coming to PK triple, the problems are with, of course, inaccurate IOL calculations and very difficult to get a rexis. So way to beat that is that make sure you're doing a closed chamber surgery. This is a 55-year-old male with ectasia and scarring. And so what you do is, in these cases, you are first doing a closed chamber phaco, and then you, once at the end of surgery, you just go ahead and insert, like do a regular keratoplasty. So it's always better. So yeah, so that's the end of my surgery talk. Thank you so much.
No, thank you. Are there any questions or comments? Because Dr. Rao has to go to another session. Are there any questions? Okay, thank you.
Thank you.
So next I invite Dr. Hijab Mehta to present her talk on achieving accuracy in biometry in post-refractive surgery cataract.
Thank you, AIOS. Thank you, Dr. Thatte, and thank you, Dr. Sushmita, for your invitation. So, accurate eye power calculation is very crucial, especially in patients who have had a previous refractive surgery, because they want a 6/6 plano. The challenges in eye power calculation in these patients is accurately determining the corneal power, predicting the effective lens position, and the changes in their corneal higher order aberrations. The ablation profile of myopic LASIK and PRK results in the greatest flattening centrally, and hyperopic treatment results in steepening centrally. The biometers, tomographers, topography devices, they measure the corneal radius of curvature in a 1.65 to 4 mm paracentral area. The central 3 to 4 mm data is not captured by this single annular measurement. These instruments, they extrapolate the measurement obtained in the 3 mm radius towards the center of the cornea, assuming a certain ratio of the anterior-posterior corneal curvature that exists in unaltered eyes. Now, this ratio is altered after laser refractive surgery, resulting in an overestimation of the corneal power after myopic treatment and underestimation after hyperopic treatment. The keratometric diopters are derived from the radius of curvature using a standardized corneal refractive index. This index is valid only as long as the proportion of radius of anterior and posterior corneal surfaces resembles that of a model cornea. This standard corneal index of refraction is no longer valid following laser refractive surgery because the ratio between the anterior and posterior corneal curvature is altered. LASIK and PRK induce minimal change in the posterior corneal curvature. However, RK induces a dramatic change in the posterior corneal curvature. To overcome the issues of the standardized refractive index of the cornea and changes in the posterior corneal curvature, the corneal refractive power can be calculated based on measurements from both the anterior and posterior corneal surfaces using devices such as the Scheimpflug or the OCT-based devices. The other problem is in determining the effective lens position. The ELP varies with the axial length and the keratometry value. It measures more in myopes and in eyes with steeper corneas. It also depends on the IOL haptic configuration, the sulcus bag location of the IOL. To predict the ELP, many IL calculation formulae use the corneal power values, which is altered post laser refractive surgery, and the predicted ELP is misleading. After myopic LASIK, the flattened corneal power values cause these formulas to predict a falsely shallow ELP, and they calculate insufficient IOL power, resulting in a post-op hyperopic surprise. The Haig's L and the Sharmas do not use the K value for ELP calculation, hence they are more accurate after laser refractive surgery. There is the Arembury formula, which proposes the double K method, where the pre-refractive surgery corneal power is used to determine the ELP, and the post-refractive surgery corneal power is used for the alpha calculation. There are different ways to do the alpha calculation. The clinical history method is no longer used because of because of a lot of inaccuracy in the alpha calculation. The combination of historical and current data, these methods are used but not so commonly. They are basically methods which modify the corneal power. They are incorporated in certain topographers such as the Atlas from Zeiss, the TMS from Tomy. Then you have methods which change the IOL power calculated, the maskets, the modified maskets. So these are also, they are used but not so commonly because there could be errors in the ultimate alpha calculation. What we use now is methods where we do not need any historical data. Basically, these are the formulae, the newer formulae, which are incorporated in the present day biometers. They are measuring the anterior corneal surface, and they modify the corneal power values, which are measured by the biometer using either regression, and they assume the posterior corneal power. The different formulae that are used nowadays are the Wang, Koch, Meloni, the Sharma's formula, the Haig's L, the Potwin Hill Pentacam, the Barrett True K no history formula. Then you have formulae which are based on measurements from both the anterior and posterior corneal surface. They are OCT based formulae, like one from the RT view, then the total K value from the IOL Master 700, which is which uses the swept source OCT technology and measures both the anterior posterior surface directly. There are ray tracing formulae. Then there is the ASCRS alpha calculator, which is an online tool which uses multiple formulae, produces one average IOL power reading. There are pop-up windows which explain the use of the calculator in detail. We need to remember that the value of the IOL that we get here depends on the amount of biometry data that we provide to the calculator. The more the data points entered, the more accurate will be the alpha calculation. Then there are intraoperative, there is AURA, which is an intraoperative wavefront aberrometer developed to calculate the IOL power based on the aphakic refraction obtained intraop after the cataract has been removed. However, the values that one gets from here will vary depending on the corneal thickness, the patient's fixation, and the IOP. It is also important to decide which intraocular lens we are going to implant following the surgery. The normal corneal spherical aberration is positive. To counter that positive spherical aberration, there are aspheric IOLs that have been designed. Post-myopic LASIK and PRK, the cornea has more positive spherical aberration, so aspheric IOLs with negative spherical aberration are preferred. Post-hyperopic LASIK, negative spherical aberration is higher on the cornea, so either aberration neutral or spherical IOLs can be used. Multifocal IOLs need to be used with caution, and EDOF can be used if the corneal ablation is regular. Now, this is one of our patients who came with cataract post LASIK surgery. The axial length, as you can see here, is about 28.7. So high myo, K values are flat. So we normally look at both the Sharma's no history. I use the lens start, so I always look at Sharma's no history and the Barrett true K value. And I try to take a value which is in between the two. So we have taken 17 T3 lens, the Alcon Toric 17 T3, which is in between the Barrett and the Sharma's no history. Patient is 6x6 plano. This is the topography map of the same patient. I look at the topography to see the centration of the ablation, also to look at the higher order aberrations. Another patient who had hyperopic LASIK, she had monovision hyperopic, right eye was corrected for distance, left for near, and she wanted the same thing after cataract surgery. So again, we looked at the Sharma's no history, and we have to mention your hyperopic LASIK, myopic LASIK, and accordingly the power value comes. So Sharma's no history and Barrett true K both. So for her, we used 21.5 2.5, which was the near emmetropic reading for the right eye, and we achieved that 6 parts with a small cylinder. Left eye, because she wanted monovision, we put 22.5, which is 2 diopters more than the emmetropic value, and we nearly achieved that. That's the hyperopic ablation pattern, steep in the center. Now this patient forgot whether she had a plus number or a minus number. She had LASIK some years back but didn't know which number. So for her, we took out 2 printouts. One was hyperopic LASIK and the other one was myopic LASIK. Both are Shama's, no history. And for her, it was very important that I go ahead and look at the ablation pattern. So here, if you can see, there is some central steepening. Central power is 43 and the periphery is, mid-periphery is 40, 41. So looks like a hyperopic ablation. The right eye, left eye also similarly, 43 in the center. Periphery is 41, 40. So we went with the hyperopic LASIK printout, and we put 22 for the right eye and we put 23 for the left eye, and we're actually emmetrope in both the eyes. So there was this paper that we looked at which compared the accuracy of just the Barrett True K formula from IL Master with the ASCRS calculator, and they concluded that both were comparable. Then you have different IOLs which can be used to tackle the post-op ametropia. You have the small aperture IOLs which are based on the pinhole effect. They provide excellent visual acuity across all distances. Then you have light adjustable lenses. The power can be modulated post-op. You have lenses where the refractive index can be modified from perfect lens technology post-op. IL power calculation post-smile, not much data. However, studies have shown that Barrett True K will work well. So just to conclude, the adjusted formulae which do not require any preoperative data are comparable to those that do. Barrett True K followed by Hager's L have good accuracy. ASCRS calculator is a good tool to have, and the spherical aberration profile of the IOL should be considered at the time of surgery. Thank you.
Thank you, Dr. Hijab. Very extensive talk, very nicely. Next, I invite Dr. Ritesh Kakrania, difficulty faced in post-RK eyes. So as all of you are aware, it's not just IOL power calculation, but it's a structurally weakened cornea, the RK cornea. So they have challenges of their own.
Thank you, AS, and thank you, Dr. Sushmita and Dr. Shreya, for getting me out of my hibernation. Let's go to 80s and 90s, where tons and thousands of young people in 20s underwent RK. Nowadays, we see few cases of post-RK cataracts here and there once in a while in our OPD and OT, but probably we are staring at a tsunami because these patients are in early 50s. So we should be prepared for these patients who have undergone RK in 80s and 90s to come for their cataract surgeries. So that is the reason this talk is important. And I would acknowledge Dr. Uday, Dr. Deepak, and Dr. Abhijit for sharing their wonderful videos so that we can all learn better. Planning a cataract surgery post-RK requires a preoperative planning, a wonderful surgical execution, and fulfillment of refractive expectations of the patient. So pre-op evaluation includes noting the best corrected visual acuity so that that can be told to the patient during the counseling time so that the post-surgery hassles decrease. When you do a slit lamp, you calculate the number of cuts, and it is important. I'm going to tell you why. Also look at the depths of the cut and note the point where you feel that the cuts are less deep. We all know that RK would lead to about 90% of the corneal thickness. The depth of the RK marks are almost about 90%, in some cases little more than that. But look out for the areas which are less deep cuts, where when the number of cuts are much more, you can plan your surgical incision at that point. And topography for incision planning, if it is feasible, always do a corneal topography for incision planning. Counseling regarding the intra-op complications and possibility of post-op surprises. With Barrett True K formula and ASCRS calculator, even post-RK calculation is almost accurate. But in case you are not able to access these, then traditional method of adding 1 diopter to 4 cut RK, 1.5 to 8 cut, and 2 diopter and for 12 cuts and beyond still holds okay. the astigmatism doesn't change. So you have to, in the counseling, you have to promise the patient that the spherical would be as near as 0, but the cylindrical value would not change unless they opt for toric. Avoid peribulbar anesthesia unless it is not feasible. Avoid doing pinky or massage because you're going to press the RK and they might give way. Mark the incision sites. Use MVR instead of lance tip because MVR you are going to make only 0.9 millimeter of incision, so it's little well controlled. If it is an MVR, you can cut and pass and go very near to the RK cuts. So MVR is preferable. Phaco setting during whole surgery, during your trenching, nucleus division, irrigation and aspiration, the fundamental is to keep the infusion pressure to around 50 to 60 millimeter of mercury rather than 90 or 100. While implanting the lens, inflate the bag. Do not overinflate the anterior chamber with OVDs because they might cause the intraocular pressure to rise and the RK cuts may just daze. We can implant IOL in with 2.2 microincision or 2.8, but remember, if the IOL is thicker, if your IOL power is nearing say 28, 29 or 30, these lenses are much thicker. So we must pay an attention and should not struggle implanting these lenses through a microincision. It is better to increase the incision size to 2.8 to deliver these IOLs. While hydrating, hydrate vertically. It is better to avoid side hydration. We don't want to include side hydration going into the RK site. So the first video where so this is an 8 cut RK with when we are planning a cataract surgery, and it's always better to mark the side port site with a Sinski. So one mark is done, the second one and the main port, so that you can visualize. It is always better to stabilize the globe so that you have a control entry into the anterior chamber. Always make sure that you control the globe so that you have a very nice control. And the main site, 8 millimeter, 8 cuts, you can still go clear corneal. More cuts, it's better to hit the sclera. Rest of the technique remain the same, except the infusion pressure should be maintained to a low level. Once the surgery is over, it is important to check whether these RK cuts have not given way. So 2 techniques are to put a large air bubble and keep pouring water and try to find out these bubbles emanating like what we see in tire punches. And the second technique is to, after completing the surgery, stain the ocular surface with sterile fluorescein and then look for a leak, like rivulet as we see in wound leaks. So once the surgery is over, the sterile fluorescein strip is smeared all across the cornea to look out for any leaks. Despite taking all these precautions, sometimes, particularly in very large number of cuts, we might face this problem. So wound adhesions, the RK cut has given way. In this scenario, you have to stop doing the surgery and first close the RK wound and then complete the surgery. It's not difficult, and the suture can easily be removed after about 3 to 4 months. Regarding the choice of IOL, it is important to understand that multifocals would have unpredictable outcomes. So what we can plan is a monofocal, a toric monofocal EDOF or a toric EDOF in such cases with wonderful outcomes. Post-op consideration, initially there would be hyperopic shift because of swelling of incision, which might last for about, this hyperopic shift might last for about 6 to 12 weeks. Do not decide to redo the surgery or break this news to the patient. Keep looking for the endothelial density because these are high myopic cases with impaired corneal integrity from RK. And post-surgery refractive surprises can be tackled by spectacle RGPs or IOL exchange. So, thank you so much.
It was really very nice presentation. RK, they always a challenge while doing any secondary surgery, and he has mentioned everything in detail, and everything was and videos were excellent. Thank you so much. The last speaker is Dr. Meena Lakshpati, and she's going to talk about the cataract surgery in pterygium.
Thank you, Dr. Shah and Dr. Tate for having me, and the AIOS also. And so when you want to plan cataract surgery in a patient with pterygium, you have to ask yourself these three questions. Like, first, ask the patient what the patient wants. Does the patient want a cosmetic surgery, or does the patient want only primarily vision? And you have to also answer this question, what you can offer the patient, whether you can offer a very good pterygium person. Is it in your expertise? Will you be able to do a very good cataract surgery in this patient with advanced pterygium? Do you want to put a very high-end intraocular lens? And then you will have to comment on whether you would want to do a simultaneous or a sequential surgery in these patients. So when would you want to do a surgery, with cataract surgery in a patient with pterygium? When it is atrophic and non-progressive, as you can see on the left side. On the right side, you will see a patient with having a high a progressive, and it's a fleshy type of pterygium, which in the absence of cataract would undergo a pterygium surgery for these reasons, such as visual acuity, decrease in visual acuity, astigmatism, inflammation, and contact lens intolerance. So why do patients with pterygium have decrease in visual acuity despite the fact that they have not yet reached the center? Is that they cause flattening in the horizontal axis. And this flattening in the horizontal axis is caused because of a tear meniscus in the head of the pterygium, which causes a severe myopic, towards a myopic shift because of the change in the flattening. So as I already said, you would do the pterygium if it's non-progressive, and you will do the cataract and the pterygium surgery if the patient is very keen for only vision and not, if you'll combine the procedure if the patient is very keen and not willing for waiting for the pterygium surgery alone. So these are some of the considerations that I've highlighted. First is you would want to do excision of the pterygium along with the conjunctival autograft. The type of pterygium, initially, many years back, they thought that just 3.2 millimeters encroachment into the cornea is necessary for decrease in the visual acuity or induction of astigmatism. Now, an encroachment of 1.1 millimeter of the pterygium into the cornea is enough to cause an astigmatism of 0.9 diopters. If any pterygium is beyond 3 millimeters, remember, you have to wait at least 3 months for astigmatic control. A surface area of cornea, encroachment of cornea of 16% of the corneal radius is enough to cause astigmatism postoperatively. So the astigmatism that caused by a pterygium is classically described as a with the rule astigmatism, where there is flattening in the horizontal axis. So predict a postoperative myopic shift. What initially in the first, what has really happened is the early part of pterygium analysis was done by some kind of keratometers. Later topography is involved, and now we have Scheimpflug devices. So now people have come out with reports with Pentacam and with other Galili like dual Scheimpflug devices, and they found that the pterygium length, the breadth, the width of the pterygium all have a bearing on the anterior and posterior corneal astigmatism. So it's important to consider that in long term, the posterior corneal astigmatism can be altered, and you may face a change in a toric lens surprise. Also consider your patient with pterygium also can have a lot of corneal higher order aberrations, and when you're planning a simultaneous or a sequential surgery, keep this in mind. So patient would opt for a simultaneous surgery because they do not want to lose their work days, they're low socioeconomic, they do not want to stay for hospitalization and the cost. But do note that there is tear film instability in these patients, and expect a myopic shift of 0.5 diopters and add this to the IOL power. Subtract this from your predicted IOL power. So the pterygium induced by the as a pterygium induced astigmatism is the function of the tear film. When would you do again? Where would you do? You would put the incision at the flatter with the area where it is away from the pterygium, either on the opposite end, or if the patient has the with the rule astigmatism, you would put it at the 90 degrees axis.
To enhance where you want, how to see the do the surgery better with a simultaneous, that is along with the pterygium, the cataract surgery. The previous speaker has highlighted the use of hooks, light pipe, and to have a better visualization. So there are many instability parameters when you do a combined procedure. So the left side, you can see the astigmatism post-operative surprises, which has occurred in one particular cohort, where the IOL power was approximated more than 1.5. So when would you follow up, when would you do a patient one after the other, the procedures? When there is severe irregularity in the astigmatism or when it's encroaching the visual axis. In sequential, remember before, when you want to do, the length of the pterygium into the cornea can be as less as 1.1, and this can matter is what the recent study says. The standard traditionalists use 1 month stabilization, but it is best to wait 3 to 6 months for corneal astigmatism to be stabilized. When you're doing sequential surgery, have the post-operative control of the pterygium excision steroids done, and look for steroid response before you take the patient for cataract surgery. And that is the graph of the predicted of the IOL power, which was less than minus 0.5 in this cohort of patients after cataract surgery. So you will choose the best type of pterygium for your patients, and for all practical purposes, I've removed recurrent pterygiums and both temporal and nasal pterygium from this talk. And you will want to offer any of these kind of lenses to the patient based upon the astigmatism that you have. You will avoid toric lenses if there's very irregular astigmatism, and if you are very skilled, you could do PTK and PRK for the astigmatism. So as I told you, on the left side, you will see scarring and pterygium-induced flattening. This is a patient who underwent panoptic toric intraocular lens 3 months after pterygium surgery in both his eyes. And this is the surgery. I think with this I will switch it on. So this is a patient who has is currently undergoing cataract surgery with the pterygium excision. Before you proceed to do the pterygium excision, you would like to put pilocarpine to constrict the pupil and nicely hydrate the side ports and avoid getting the AC flat. The pupil is constricted so that because the duration of the surgery is increased and you do not want to have a lot of bright light passing into the retina. See, all the tags of the pterygium tissue is removed from the cornea. You would go ahead to proceed with excision of the subconjunctival pterygium tissue. The dystrophic pterygium overlying the body of the pterygium is removed. And just like the routine cautery, we would do a wet field cautery. You would measure, and directly I usually place the steel calipers and mark the areas of where I want to actually. So one thing I would like to say is both for sequential and for simultaneous pterygium, now I have started doing only inferior conjunctival autografting, because when you want to do pterygium first and later cataract surgery, the wound healing will not be altered, especially if it's superior. And I have placed the Merocel sponge to dry this bed of the donor site, and then you place both the components of fibrin glue and close the defect with the autograft. So these are patients, so you would attempt manual keratometry in all the patients pre and post and decide what kind of keratometry you want to do. So the patient on the left side had a manual keratometry. The digital biometry gave a good reading. We went ahead and used that. But on the other side, where you can see a progressive pterygium, we had to use a topo K because of irregular astigmatism. Mitomycin C is generally avoided. So for small pterygium, my take-home message would be to go ahead with cataract surgery. Avoid any kind of premium lenses if the astigmatism is severe, and always ask the patient what they want, whether they want vision first or whether they would like to have, they want to wait and get a cosmetically better visual outcome. Thank you.
Excellent presentation. I think many questions are answered. Anybody has any question?
So I think we'll start with Dr. Charuta. So you mentioned about punctal use of punctal plug that you use, if you're taking up a patient of SJS. So regarding, I was just curious about other conditions like RA, etc., collagen vascular disease. So would you like to put up a plug in those cases also, or what is your take on those
So
eyes?
actually, sometimes in RA patients especially, we see more of mucus secretions later on if we use punctal plugs. So that sort of interferes with the clarity of vision. I don't prefer in RA. I prefer definitely in SJS patients. Yeah, because the mucoid discharge is more after punctal plugs.
Not even a temporary plug. So I usually in my practice use a temporary plug which is there for about 3
In my
months and then.
hands, frequent lubricants work better, but I know
Okay.
it's been described as.
Anybody else would like to comment on this? Yeah, please. Mike.
Like for example, patients with OCP or Steven Johnson or RA, okay, not maybe not RA, but these ocular cicatrizing disorders, I prefer to give perioperatively IV methylprednisolone, just to have a uneventful course post-operatively. I don't know what others are doing.
Yeah, I think I also agree. Single shot of IV
Yeah.
methylprednisolone
That will
is
reduce the inflammation.
yes, reduce the inflammation. And the other question was, Dr. Charuta, is many times if they are on contact lenses, the semi-scleral, etc. So how do you go ahead with the IOL power calculation? Do you think that interferes? You need to take anything special?
Definitely, we have to get him off the rigid lens at least for 2 weeks. Then only do the IL power calculation. But it's difficult because they are so heavily reliant on if they are using RGP lenses.
Yeah, and also situations in let's say OCP who are often with systemic immunosuppression. Do you hike up the immunosuppression or do anything additional for the
So,
cases?
in Hyderabad, we have like a set of rheumatologists who take care. But in concurrence with them, then we request them to step up the immunomodulation and give also a short course of steroids. Definitely.
Yes. Any comments from the other speakers?
Dr. Hitesh, if you find in cases of RK, if you find that the incisions are almost 90% depth, do you prefer to give pre-operative sutures in those places, so not to give up those incisions?
I do not prefer giving
You
preoperative
do not
sutures. I
prefer.
tackle it
Oh.
as it comes during the surgery.
Because they may obstruct, they may change the corneal
So
curvature
I go with all the
and
armamentum
difficulty in
of
the
what
surgery.
wrong would happen, keep myself mentally ready for these shortcomings and tackle it as I face them.
And would you think of a scleral tunnel incision for doing the
Yeah, he
surgery?
mentioned.
Yeah, so the rule was if you have 4 cuts, you can still go clear corneal, 8 cuts, clear corneal, 12 cuts, find out the flatter or the less deeper RK cuts and plan your incision there. Always mark your incisions lest you forget during your surgery in your big list. And anything more than 12, hit the sclera. So go beyond the cornea.
So what I do is anterior segment OCT. I think it really helps in delineating the cut. Sometimes if the cut is full thickness, those can happen. You can see a mild amount of the desmet wrinkling and things like that. So we need to keep that in mind. Just be careful of watch out that area and be mentally prepared.
Such cuts would give way the moment you enter the anterior chamber with your phaco probe. You have
Yes,
to
yes,
immediately stop, take a suture, and complete the surgery.
yes. Anybody has any experience with use of fibrin glue of the RK opening up?
I did
and-
one. It was a
in-
micro leak, a very small leak, and it closed and it didn't leak again.
So you just put a glue and not not a suture and it worked out.
It
Yeah,
was a very small glue. I used air, not
He
the
said
fluorescein
micro.
strip,
yeah.
but it was so small that it worked with the glue.
No, that's good.
Dr. Meena, you have gone through the literature in detail about the pterygium in cataract. Did you find anything, anybody has come up with any formula or anything which can we can predict how much astigmatism this type of pterygium, this much of grading can cause, and so that we can go for the accurate IOL power calculation. Have you seen that?
What has happened is the initial publications which came about pterygium were in certain universities in US, and now it is now regarded as a low socioeconomic problem. So most of the publications that you will see will be from smaller universities. So there are no long-term or randomized trials or anything specifically done. Getting the post-operative care to be predictable has been a challenge all through this while. Although newer devices have come, everything is plus or minus 0.5. So tan grade 3 and above pterygium have always will remain a problem of post-operative predictability.
I think I'll ask one question to Dr. Hijab. So you showed very nicely 2-3 of your cases where you have used two formulas, and so do you typically recommend that we use a couple like the two formulas which you mentioned, that we do the alpha calculation based on two, and then so you said something like you take a midpoint between the two, or how do you do it? Just explain again.
So we use LensStar. So LensStar, there are two formulae, Barrett-Truque and Sharma's. Sharma's always gives a slightly more myopic reading, and Barrett-Truque gives a slightly hyperopic reading. By that I mean Barrett-Truque will say 16.5 is targeting minus 0.2, and Sharma's will say 17 is targeting minus 0.2. So I try to go, if I'm doing a myopic LASIK, I will look at Sharma's. I want a slightly more myopic reading. If I'm doing a hyperopic LASIK, then I don't want a myopic reading. Then I look at Barrett-Truque.
Okay.
Because that's giving me a little hyperopic reading. So always two formulae, always. I may still just, for the heck of it, look at the others, but primarily these two. And I honestly don't look at the ASCRS Barrett calculator because I know my machine. I keep looking at, I select my IOLs and I know my topographer also. So I can correlate, and also I'm using one IOL platform, so I know that Alcon Clarion will give me this result, Alcon IQ will give me this result. So for me, I mean, not for me, that should work. I mean, you should know your biometer well, which platform of IOL you're using well, because that ultimately will
Absolutely,
determine
yeah.
the effective lens position. So if you have that in place, you really don't need to look at multiple things. If you are an IOL master user, then maybe you look at Hage's L. You will not have Sharma's, no history in that. You'll have
Yes.
Barrett-Truque and you'll have Hage's L. So you look at Barrett-Truque and Hage's L. So the more, I mean, I don't
Yeah.
think it requires some special skill.
Yeah. Thank you so much, Dr. Hijab. Yeah, I think almost done. Yeah. So if are there any other questions or comments? So with that, I think since time is also over, we'll conclude the session. I thank all the speakers, the audience, and Dr. Shreya. Thank you very much for a wonderful session. Thank you. Yeah, please come for a